Alterations in oxygenation, lower respiratory disorders. Acute bronchitis is inflammation of mucous membranes caused by Haemophilus influenzae, Streptococcus pneumoniae, and Mycoplasma pneumoniae, in addition to a fungal infection such as Aspergillus. These clients experience fever, chills, malaise, headache, dry, irritating, and non-productive cough, or mucopurulent sputum. These clients require bed rest, antipyretics, expectorants, antitussives, increased fluids, or antibiotics. Nurses need to monitor lung sounds, vital signs, and encourage the coughing and deep breathing. Pneumonia is an inflammatory process that affects the bronchioles and alveoli. Categories include radiation, chemical, and aspiration, bronchopneumonia with the lobar pneumonia, and community-acquired pneumonia or hospital-acquired pneumonia. These clients experience fever, chills, a productive cough, discomfort in the chest wall, malaise, or a rust-colored sputum. We treat them with antibiotics, hydration, oxygen, bed rest, chest physiotherapy, postural drainage, bronchodilators, analgesics, antipyretics, and cough expectorants or suppressants. Nurses need to complete a respiratory assessment, including the lung sounds, pulse oximetry, and maybe some ABGs. Cough and sputum assessment should be done. Positioning, the semi-Fowler's position may be the most beneficial. Pleurisy is the inflammation of the parietal and visceral pleura. We see shallow respirations and excruciating pain, dry cough. The client fatigues easily. They experience dyspnea or have a friction rub. We treat it with analgesics and antipyretics along with NSAIDs. Nurses administer the medications, apply heat or cold, teach the client how to splint the chest, and provide emotional support. Pleural effusion is an abnormal collection of fluid between the visceral and parietal pleura. Causes include tuberculosis, lung cancer, or cardiac issues. Clients experience fever, pain, dyspnea, a friction rub. We diagnose through chest x-rays, a CT scan, or thoracenteses. These clients require antibiotics, analgesics, cardiotonic drugs, and chest tube insertion. Nurses will help prep the client if a thoracentesis is done or a chest tube is inserted, in addition to monitoring the chest tube function and drainage should that be part of the treatment. The lung abscess or empyema. Empyema is a general term that's used to indicate pus in a body cavity. In this instance, it may be infected fluid found in the pleural cavity. An empyema can follow chest trauma, such as a stabbing or a gunshot wound, or maybe a pre-existing disease such as pneumonia or tuberculosis, or a lung abscess. These clients will experience fever, chest pain, dyspnea, anorexia, and malaise. They may also have diminished or absent breath sounds over that affected area. We're also going to do a chest radiograph. To treat, we may do a needle aspiration to help identify the microorganisms or to remove the pus or fluid. Antibiotic therapy. They may require a closed drainage, which would involve a tube thoracotomy being inserted, those large chest tubes, and then connect that to a chest drainage system. An open chest drainage might be done, which would require the removal of a section of one or more ribs, and that may require one or more tubes being placed in that opening to help promote drainage. Now, if the empyema becomes chronic, a thick coating can form over that lung, and it will prevent complete lung expansion. And this may require decortication, which is removal of that coating and evacuation of that pleural space, which will allow that lung to then re-expand. Since empyemas do take a long time to resolve, the client will require emotional support during this treatment. And the nurse also needs to teach the client those breathing exercises. This shows lung areas that are to be drained and the best postural drainage positions for those particular areas. Influenza is an acute respiratory disease, and we see a major strain of A, B, and C, and then there's subtypes. Clients experience a severe headache, muscle aches, anorexia, sore throat, laryngitis, nasal discharge, and dry cough. Now, the flu is not to be confused with an intestinal virus. Influenza is definitely a respiratory situation. We treat it by being preventative, making sure these clients get the flu vaccination. And if they do come down with it, we need to isolate them in a hospital setting. Then we're going to treat them appropriately, basically treating symptoms, because it is a virus. We also know that if clients get the influenza, that there are drugs such as the antivirals Tamiflu, which if they're administered early on in the disease process can help shorten the disease or decrease the severity. Nurses, once again, need to push the prevention of the vaccine. Pulmonary tuberculosis is a bacterial infectious disease caused by the Mycobacterium tuberculosis. These clients have an insidious onset. They may experience fatigue, anorexia, weight loss, and a slight non-productive cough. Later on in the disease process, they may experience night sweats, a cough that's productive of mucopurulent and blood-streaked sputum. We may see weakness, wasting, hemoptysis, and dyspnea with these clients in the later stages. We diagnose by doing that mannitol-tuberculin skin test, chest x-rays, CT scan, or an MRI. And we treat it with drug therapy. The drug therapy is very extensive. It takes several weeks of treatment, in fact, months of treatment, and we see a lot of non-compliance. So sometimes these clients are going to require a visualized taking of the medications to help make sure that they comply with treatment regimen. Now, when you are looking at a TB skin test, this gives you some guidelines as to how to determine if a skin test is positive or negative. So it can be positive if it is over 15 millimeters of induration in the general public that does not have risk factors. Now, if it is a client that is in a long-term care facility, an IV drug abuser, or someone who has medically underserved population or healthcare workers, it only needs to be 10 millimeters and less than 5 millimeters in a client that is an HIV positive or has recent close contact with someone that has active TB. And remember, we always look at these within 48 to 72 hours. And if the client does not have that 48 to 72 hour inspection, they have to do it all over again. So we have a 17-year-old client's mother that has recently been diagnosed with TB. The nurse would expect the physician to order which of these following tests initially? And that will be the Mantoux test. Bronchiectasis is a chronic infection and irreversible dilation of the bronchi and bronchioles. These clients have a chronic cough, expectoration of purulent drainage, fatigue, weight loss, anorexia, and dyspnea. We treat them with antibiotics, bronchodilators, and mucolytics, in addition to humidification. That humidification helps keep the secretions moist and thin. Nurses need to do the postural drainage techniques, chest percussion, and encourage oral hygiene. Atelectasis is a collapse of the alveoli caused by aspiration, a mucus plug, fluid or air tumors, an enlarged heart, aneurysm, or prolonged bed rest. These clients may have cyanosis, fever, pain, dyspnea, an increased pulse and respiratory rate, and increased secretions. We diagnose with chest x-ray, ABGs, and pulse oximetry results. We need to improve their ventilation, and we do this through suctioning, deep breathing, coughing, bronchodilators, and humidification, and administer oxygen. Nurses encourage that deep breathing and coughing, and we use the incentive spirometer to help expand those alveoli. Chronic bronchitis is the hypersecretion of mucus and recurrent or chronic respiratory tract infections. It can be caused by bronchial asthma, influenza or pneumonia, air pollution, and smoking. Early on, we see a chronic cough that's productive of thick, white mucus, and clients may also have bronchospasms. We need to prevent recurrent irritation and remove those secretions. Encourage smoking cessation, administer bronchodilators, increase fluids, do postural drainage, and steroid therapy. Nurses need to focus on prevention, education, such as eliminating those environmental irritants, how to administer the metered dose inhalers, doing the postural drainage, and rest. With the COPD guy, I really want you to look at his positioning. This is what we call the tripod position. They tend to lean over a table or put their hands or elbows on their knees. This helps them expand their lungs to their fullest capacity. Emphysema is a chronic disease in which we see abnormal distension of the alveoli. These alveolar walls and capillary beds are going to start showing marked destruction. And this process is not something that just happens overnight. It does occur over a long period of time. But by the time the clients are diagnosed, that damage is usually permanent. Emphysema is the most common obstructive lung disorder. So we see the alveoli beginning to lose elasticity, and this traps air that the client would normally blow out. Eventually, we're going to see scarring in the alveoli, and destruction of the alveoli, and this prevents the proper exchange of oxygen and carbon dioxide during respirations. As the disease progresses, those large air sacs can be seen over the lung surface. Those sacs can rupture and allow air to enter the thorax, which is what we call the pneumothorax, and we'll discuss that a little bit more in depth later. These clients experience shortness of breath with minimal activity, and that's usually the first symptom we see. And as the disease progresses, that breathlessness is going to occur even at rest. A chronic cough will develop, and it will be productive of mucopurulent sputum. And the chest will have that characteristic barrel shape. Because the air becomes trapped, it causes that chest to begin to expand. And if you look at the picture on page 336 of your textbook, you can see a good example of that barrel chest. The client will use accessory muscles to breathe, and expiration will be prolonged, often difficult, and may have wheezing associated with it. These clients are going to appear drawn, they'll be anxious, and they'll be pale. They speak in short, jerky sentences because they just don't have the air to talk. And neck veins can also be distended during expiration. As emphysema advances, clients may experience memory loss, drowsiness, confusion, and loss of judgment. If left untreated, the carbon dioxide content can become toxic, and that will result in lethargy, stupor, and eventually coma. It's called carbon dioxide narcosis. With carbon dioxide narcosis, we see decreased breath sounds, wheezing and crackles, diminished heart sounds, and that barrel-chested person, again, is breathing through pursed lips and using accessory muscles to breathe. We diagnose emphysema with chest x-rays, fluoroscopy and CT scans, pulmonary function studies, and ABG analysis that would reveal hypoxemia and respiratory acidosis. The goal of medical treatment would be to improve the client's quality of life, slow the disease progression, and treat the obstructed airways. Treatment is going to include bronchodilators, aerosol therapy, inhaled corticosteroid drugs or oral steroids, supplemental oxygen, antibiotics, and physical therapy. If these treatments are not effective, the client is going to begin to have progressive loss of sleep, appetite, decreased weight, and decreased physical strength. Nurses need to monitor oxygen levels, administer oxygen per nasal cannula no greater than 2 to 3 liters per minute. The thing about chronic obstructive pulmonary disease is our normal trigger to breathe is a low level of oxygen in our blood system. With the COPD patient, their trigger to breathe is the high level of carbon dioxide. So if we start administering too much oxygen, we're going to take away that carbon dioxide, and we're going to take away their trigger to breathe. So they can go into respiratory arrest. Nurses also need to teach therapeutic breathing exercises, such as diaphragmatic breathing, or maybe blowing out candles at various distances or blowing objects across a table. We also need to provide client education to help them adjust to their current level of disability and their potential for increasing disability in the future. Nutrition-wise, we know that labored breathing increases calorie requirements. So these clients may require a high protein, high calorie diet. Although we want to walk that fine line and prevent excessive calorie intake because that increases respiratory stress by increasing carbon dioxide output. We also want to think about giving small frequent feedings of a nutrient-dense food. It takes a lot of energy to breathe. It takes a lot of energy for these clients to eat. So we may also want to administer concentrated liquid supplements and make sure we encourage ample fluid intake. If a client is overweight with emphysema, we may want to encourage weight loss to help improve their breathing. So asthma is an inflammation and bronchoconstriction of airways and hypersensitivity of airways. We may see allergic or non-allergic asthma. We diagnose through chest auscultation and pulmonary function studies. These clients are going to be short of breath. They may experience wheezing, coughing, produce thick sputum, and prolonged expiration. Medical management includes avoiding those allergens, administration of antihistamines, doing desensitization, such as allergy shots, or pharmacological issues such as inhalers or nebulizer treatments. Nurses teach that medication administer oxygen as necessary, and teach that inhaler use. We also teach a client how to do peak flow monitoring. So the nurse is instructing the client with asthma about the importance of measuring peak flow rates. Which of the following statements about the purpose of measuring peak flow rates is correct? The correct answer is B. They measure his response to the bronchodilator therapy. Cystic fibrosis is a faulty transport of sodium and chloride, the production of abnormally thick, sticky mucus. It's inherited and it's caused by a defective autosomal recessive gene. These clients have frequent respiratory infections, cough, purulent sputum, thick mucus, finger clubbing, hemoptysis, a failure to thrive, greasy stools, and salty tasting skin. We treat them with bronchodilators, respiratory treatments such as the physiotherapy, sometimes putting on a vest that provides a continuous vibration, diet management. These clients require increased salt in their diet because they are diaphoretic and they are getting rid of an excessive amount of salt. And sometimes pancreatic enzymes because they may become hyperglycemic. Surgically, these clients may require a lung transplant. Nurses are going to be doing the chest physiotherapy, encouraging postural drainage. We may also do the vigorous percussion and vibration. So there's different occupational lung diseases that we look at, such as pneumocanosis, which is an inflammation of the lungs from a dust or gas, silicosis, which is inhalation of silica, coal dust, which causes that black lung, and you see a picture of that in your slide. Asbestosis, which is inhalation of asbestos. We treat it by preventing it, promoting dust control, proper ventilation, protective masks and hoods, and sometimes even industrial respirators. Nurses are going to encourage respiratory treatments and emotional support. Pulmonary arterial hypertension is a resistance to blood flow in the pulmonary circulation that causes pulmonary arterial hypertension. These clients may experience dyspnea, weakness, chest pain, fatigue, jugular vein distension, orthopnea, and peripheral edema. We administer vasodilators, anticoagulants, manage their underlying cardiac and respiratory disease. Nurses need to recognize the signs and symptoms of respiratory disease, help the client prevent fatigue, and assist with their ADLs in addition to administering oxygen. A pulmonary embolism is the obstruction of a pulmonary artery or branches, usually from a blood clot. Excuse me. These clients have an immediate onset of pain, tachycardia, and dyspnea. They may also experience fever, cough, blood-streaked sputum, cyanosis, and an irregular heart rate with wheezing. We treat it with IV heparin or an IV thrombolytic drug, and sometimes an embolectomy may be done. We definitely need to prevent DVTs. So remember clients who have had surgery, especially of the hip or pelvis area or the leg, they are at extreme risk for deep vein thrombosis. And those are going to be one of the big causes of pulmonary emboli. The acute respiratory syndrome. The acute respiratory distress syndrome is also known as ARDS, and it occurs following other clinical conditions. The less severe form is referred to as acute lung injury. Now, acute lung injury and ARDS are not primary diseases. ARDS can lead to respiratory failure and death, and it's also referred to as the non-cardiogenic pulmonary edema. In other words, the pulmonary edema is not caused by a cardiac disorder. So, different things that may lead to the development of ARDS is aspiration, drug or alcohol ingestion or overdose, blood disorders such as DIC or massive transfusions, lung damage through prolonged smoke inhalation, pneumonia, metabolic disorders, trauma, major surgery, embolism, and septicemia. It's important to know that the mortality rate with ARDS is very high. So what we're going to see is development of sudden and progressive pulmonary edema, and this causes a decreased gas exchange that results in respiratory and metabolic acidosis. We also see a decreased surfactant production, and the lungs become stiff and non-compliant. And then we begin to see severe hypoxia and hypocapnia. On chest x-rays, we'll see increased bilateral infiltrates, and we need to know that ARDS will develop within 8 to 48 hours after the onset of an illness or injury. These clients will experience an increased respiratory rate, shallow labored respirations, cyanosis, the use of accessory muscles, respiratory distress that's unrelieved with oxygen administration, anxiety, restlessness and mental confusion, agitation and drowsiness with cerebral anoxia. We diagnose by looking at whether there is acute respiratory failure, bilateral infiltrates on the x-rays, and hypoxemia with supplemental oxygen. So again, we are going to do chest x-rays to help diagnose this condition. We treat it with humidified oxygen and insertion of an endotracheal or tracheostomy tube, and provide mechanical ventilation with PEEP, or the positive end expiratory pressure. We're also going to do ABGs to monitor how the treatment's doing. We may see hypotension. We're going to monitor the pulmonary artery pressure. We may administer colloid intravenous fluids to help pull fluids from the interstitium into the capillaries, and we need to provide adequate nutritional support. Nurses are going to focus on promoting oxygenation and ventilation and preventing any complications. We also assess and monitor a client's respiratory status and provide alternative methods for a client to communicate. Respiratory failure is the inability to exchange sufficient amounts of oxygen and carbon dioxide for the body's needs. Causes can be acute or chronic and include COPD and neuromuscular disorders. These clients are going to be apprehensive, restless, may have wheezing with respirations, exhibit cyanosis, dyspnea, hypoxemia, and hypercapnia. We need to help maintain a patent airway, administer humidified oxygen, and we may require or may administer mechanical ventilation. Nurses need to obtain emergency resuscitative equipment and make sure you assess the respirations and monitor the vital signs. Malignant disorders such as lung cancer is from a prolonged exposure to carcinogens such as cigarette smoking. These clients will have a cough that produces mucopurulent or blood-streaked sputum, anorexia, weight loss, dyspnea, and chest pain. We diagnose through chest x-ray, CT scan, PET scan, MRI, or bronchoscopy. We treat it through chemotherapy and radiation or surgical management by removing a lobe or sometimes an entire lung, which would be a lobectomy, or the lung would be a pneumectomy. Nurses need to provide emotional support and postoperative care. Excuse me, it's important to realize that a lot of times lung cancer is discovered late in the process because there's so few symptoms to help indicate there's an issue. And often the lung cancer is discovered by accident. For example, doing a chest x-ray for a preoperative procedure. Trauma of the lungs can come from fractured ribs, where we have a blunt or blunt force trauma. We may also see the flail chest, in which there is more than one fracture in a rib in multiple ribs. So we basically have a section of ribs that has completely fractured and is separate from the rib cage itself. And with that condition, we see the asynchronous movement of the chest wall where that fracture is. So normally when we breathe in, we're going to see the rib cage expand, but with the flail chest, that fractured area is actually going to go inward. So it's called a paroxysmal chest movement. These clients may also experience severe pain with inspiration and expiration, and they may have respiratory acidosis. They have pain, so they're not breathing very well. They're not breathing deep. They're not blowing out that carbon dioxide. We treat it with an elastic bandage or rib belt. However, that can lead to decreased respiratory movement. And we also need to make sure that we treat with analgesics. Penetrating wounds can be caused by a penetration such as a knife, or we may have a gun wound. And this can create a pneumothorax in which air is going to enter the chest cavity instead of the lung itself. And then we have a collapse of the lung. We may have a hemothorax in which the lung collapses because of the accumulation of blood due to an injury. These clients will also exhibit subcutaneous emphysema, in which the air, instead of going into the lung, is now going into the tissue. So the subcutaneous emphysema is kind of like the Rice Krispies when you palpate the skin. You actually feel the air in the tissues popping like bubble wrap when you palpate the skin. We may see hemorrhage, a lung contusion, or damage to the surrounding tissues, and these clients may also have fractured ribs. A fractured rib can actually puncture a lung and cause a pneumothorax. So it's important for the nurses to manage the airway and provide emergency treatment. Thoracic surgery is frequently called a thoracotomy, in which the thorax is opened. We do this to remove fluid, blood, or air. We can remove tumors, remove a lung portion or an entire lung, repair structures, repair trauma, or do a biopsy. Preoperatively, make sure you're doing that lung assessment and obtaining an appropriate history. Postoperatively, again, lung assessments, and potentially we're going to be doing chest tube management. So the client's left thoracotomy tube is connected to a water-sealed drainage and suction. The client is going to be transported to the X-ray department. How does the nurse transport this client? The nurse will disconnect the suction and maintain the water-sealed drainage. It does not have to be connected to suction. It can be removed from the suction, for example, the low intermittent or low continuous wall suction.